This echocardiographic video belongs to a patient who previously underwent aortic valve replacement, AVR. The striking finding is significant turbulent flow with markedly elevated transprosthetic gradient across the bioprosthetic valve. At first glance, this may raise concern for prosthetic valve dysfunction. The immediate questions are the valve leaflets opening normally? Is there prosthetic valve thrombosis? Is a structural valve degeneration present? Or could this simply represent patient prosthetic mismatch, commonly known as PPM? Patient prosthesis mismatch occurs when the effective orifice area of a normally functioning prosthesis is too small for the patient's body size. In other words, the prosthetic valve itself opens normally as it does in this case, but it is simply too small to meet the patient's physiological requirements. One of the most common mistakes is to diagnose prosthetic valve obstruction based solely on a high Doppler gradient. A high gradient doesn't necessarily indicate valve dysfunction. A perfectly normal prosthetic valve may generate high velocities simply because it is too small for the patient's body size. PPM is therefore a hemodynamic interaction between the prosthesis and the patient's body size. This transesophageal echocardiographic examination demonstrates normal leaflets motion, normal leaflets thickness, and no evidence of thrombus or structural degeneration. Always remember that increased transprosthetic flow can substantially increase Doppler gradients. Patients with anemia, sepsis, hyperthyroidism, AV fistula, and pregnancy may develop very high gradient despite a normal prosthesis. So always ask, is the flow unusually high? This 3D TE view also confirms thin and mobile leaflets without evidence of obstruction. This is a short axis view of the prosthesis, indicative of a normally bioprosthesis. Patient prosthesis mismatch is the only cause of prosthetic valve stenosis in which the prosthesis is completely normal. The problem lies not within the valve, but in the relationship between the valve and the patient. As it's seen in this 3D view, the valve is normal. Misdiagnosing PPM can lead to prolonged anticoagulation, inappropriate thrombolysis, unnecessary reduced surgery, and unnecessary CT or transesophageal echocardiographic examinations. True prosthetic stenosis usually produces a prolonged acceleration time. In contrast, patients with PPM often shows relatively normal acceleration time, despite elevated gradients, like this image. The Doppler velocity index, DVI, is also extremely useful. It is the ratio of LVOT VTI to prosthetic valve VTI. If DVI is preserved, valve morphology is normal, but high gradients persist, PPM becomes much more likely than prosthetic obstruction. PPM is not limited to bioprosthetic valve. It can occur with mechanical valves and transcatheter heart valves. Interestingly, severe PPM is generally less common after TAVI than after surgical AVR. Mean gradient depends on stroke volume, heart rate, valve size, and patient's body size. For this reason, the pressure gradient alone should never determine the diagnosis. Indexed effective orifice area is the key, calculated by dividing the measured effective orifice area by the patient's body surface area. If indexed effective orifice area is more than 0.85 centimeter square over meter square, there is no significant ppm. In the index effective orifice area between 0.65 to 0.85 centimeter square over meter square, moderate ppm, and less than 0.65 centimeter square over meter square means a severe prosthetic patient's mismatch. In obese patients, lower cutoffs should be used because indexing to body surface area may overestimate the severity of ppm. The straight DTE demonstrates a small swing ring but normal discs motion. When gradients are elevated, evaluate the following systematically: leaflet or disc motion, Doppler velocity index, effective orifice area, indexed effective orifice area, previous echocardiograms, and clinical symptoms. Most valve manufacturers publish expected hemodynamic performance, including effective orifice area, expected pressure gradients, and regurgitation characteristics. These values are usually available in the instructions for use, IFU. It is often not the best reference because it is derived from in vitro testing. If the measured effective orifice area is close to the manufacturer's expected value, but the indexed effective orifice area is low, ppm is the likely diagnosis. Conversely, if the measured effective orifice area is significantly lower than the expected value for that valve model and size, true prosthetic obstruction becomes much more likely. Following successful AVR and relief of severe aortic stenosis, LV hypertrophy should regress. Severe ppm may blunt LVS reverse remodeling. Therefore, persistent LV hypertrophy months after AVR should raise suspicion for clinically significant ppm. In this deep gastric TE view, aortic mechanical valve motion appears normal, indicative of a ppm. Another important pitfall: pressure recovery can mimic ppm, especially in patients with a small ascending aorta. In these patients, Doppler may overestimate the true transvalvular gradient. This can falsely suggest prosthetic valve obstruction or ppm. Finally, the practical algorithm. Whenever you encounter a high prosthetic valve gradient, assess leaflet or disc motion. If abnormal, consider thrombosis, pannus formation, or valve degeneration. If valve motion is normal, calculate the indexed effective orifice area. Indexed effective orifice area less than 0.85 centimeter square over meter square suggests ppm. If ppm is excluded, search for another explanations, such as high flow states, pressure recovery, or measurements error. In conclusion, treat the patient, not the gradient.